Okay, good morning, everybody. Good morning. What a beautiful day. I'm Luke Jackson. I am the director for inpatient psychiatry here at USC Verdugo Hills Hospital. I want to welcome you to our conference. I want to start you off by introducing you to Teresa Murphy, our Chief Nursing Officer, and I'm going to ask her to go ahead and open this up for us. Teresa.
Well, thank you, Luke. So I'm Teresa Murphy, as Luke said, Chief Nursing Officer here at USC Verdugo Hills Hospital. I'd just like to welcome you today. We like to say welcome to our living room. And so we'd like you to just make yourselves as comfortable as you can on wooden chairs. We are really looking forward to this seminar today, and we are proud to partner with Horizon Health, who provides our behavioral health programming here at Verdugo Hills Hospital, to partner with them to bring this program to you today. Thank you to all of our volunteers. If any of you have questions or need assistance, please reach out to one of our volunteers. And we're so happy to have our nursing students here who are doing dual duty here, learning and helping out. So thanks for being with us today. I'd like to also acknowledge Luke Jackson. This seminar is really the brainchild and vision that Luke had 3 years ago, and has put this into motion and really the architect of this day. So this is now our third annual Courageous Conversation about suicide prevention, a topic that's important, certainly a very salient topic to our community. So again, welcome. We're so glad you're here today. And with that, I'll hand it back to Luke.
Thank you, Teresa. Thank you very much. Okay, so I have a question. For how many of you have been to this conference before? Show of hands. So close to half of you, okay? And so we have a lot of new people, and I'm really grateful for that. I know that some of you probably had to struggle to get registered and get in because we actually had such a response. We actually turned quite a few people away. So I'm really glad you all were able to make it. Unfortunately, with the space we have, we're doing the most we can. We are recording this year, and we're going to be showing it in the other room. So if you decide you need to get a break from this big room, there is a smaller room that we have this being broadcast in. A couple of housekeeping things for you. And can I turn this on? Don? Can I turn this on? I don't like to hold a mic. I don't know what it is. I need to fidget with my hands. Okay. So I wanted to start off, very quickly, I wanted to say a very big thank you to some of our sponsors. Our sponsor tables are outside the doors here and up and down the hallway. Please stop by and say hello to them. They come out each year and they help us put this together. They sponsor us. They help us defray some of the cost of providing the conference so that you all can come and enjoy the presentations that we have. So La Crescenta Healthcare, very big sponsor, please. Round of applause for them. East West Bank, also sponsoring us here today, friend sponsor. Broadway Manor Healthcare, Montrose Healthcare right down the street, New York Life, and for the first time, Seasons Hospice, which is actually my old hospice. So welcome and thank you for those. And finally, a special thank you to the Mary Panola Crescenta Valley Chamber of Commerce Education Fund. Gave a special, I can't talk today, special sponsorship to promote the CEUs and get those available for everybody. So very much thank you to them. We have a number of additional sponsors that are out here. You've seen them, Department of Mental Health and a variety of other not-for-profits who show up and support us each year. So thank you to all of them. A couple real quick restrooms. I know everybody at some point is going to need the restroom. We do have right outside this door to my right, there's a men's and women's restrooms. Down, if they're real busy, down the hallway, keep going down the hallway by the elevators. Right on the other side of those, there's restrooms. And if they're super swamped and you need to get somewhere fast, down on the third floor, across from the main entrance there's also additional restrooms. So we should be okay with that. One thing I like to ask people is if you go through the doors, make sure you go through gently. If the doors close too hard and somebody's speaking, it can be a kind of distraction. I'd like to ask everybody to silence their cell phones, please. It's something it's very easy to forget. I know I often do. And then it like, bing, goes off. Okay. So let's get started. This is our third annual suicide prevention conference here. This was started a few years ago in recognition of Worldwide Suicide Prevention Day, which is September 10th, I believe, coming up in a couple of days. Every year we see an increase in suicides, not only in our own country, but around the world. And fortunately, we have more and more people beginning to really pay attention to this. And it is a worldwide phenomena. It is basically a catastrophe for our country right now. And there's a lot of reasons. We talk about that. There's a lot of things that people are doing. We're going to talk about that. And I want to start by introducing our first speaker. Dr. Alex Crosby is an epidemiologist, a medical epidemiologist who works for the CDC. I don't know if any of you have ever heard from an epidemiologist, but you're going to hear from one today. And the reason you're going to hear from him is he has devoted his career working at the CDC in addressing the causes and analysis of what's happening with suicide across the country and what are people doing about it. So he's going to give us a big view of what's going on all around the country. Dr. Crosby has been doing this kind of work and many other types of work that bring him to the forefront of the issue. So please give a big round of applause to Dr. Alex Crosby.
Well, good morning again to all of you. I know you guys can say good morning, right? I know you've come here to learn some stuff and to interact with some, but you can still be friendly too, right? Okay, all right. Well, good morning to all of you. I did want to thank the sponsors, not only the sponsors that have contributed to the resources, but also USC Verdugo Hills Hospital for the invitation to come and to talk with you. Mr. Jackson, Ms. Panchal for inviting me here to come and to talk to you. And you can see that what I'm going to talk about is how we use data. And you can see from the very title, what's data got to do with it? So a few of you will know that Tina Turner song, right? What's love got to do with it? So I'm going to talk about what does data have to do with it. Why is data important? What do we use it for? Because sometimes it can seem like a burden, right? We've got to collect information. We've got to write stuff down. We've got to enter it into the computer. You know, how is that really helping us? But I'm going to try to convince you that data is an integral part of what you do. We oftentimes, and we really want to make sure that we're putting programs into place that are trying to prevent suicide, that are trying to prevent mental illness, that are trying to prevent people from having the consequences of those kind of things. But we've got to be informed about what it is that we're doing to make sure that we're making the right kind of decisions about how those programs work, about what kind of populations we want to target, which are the groups that are at risk, what do we know about risk and protective factors. All of that information kind of goes into that data. And so I'll talk a little bit about what data's got to do with it, what kind of things are available, some of the things that the Centers for Disease Control and Prevention does, and what kind of information is available for you to use, sometimes at the local level, sometimes at the state level, sometimes at the national level. So I'll talk about that quite a bit today. One of the things that I'll kind of start off with in terms of kind of laying out a plan for you is one of the ways that CDC tries to address any kind of health condition is what we call the public health approach. And really, it's not anything really, really sophisticated, even though at CDC we like to think we're really smart, know a lot of stuff, but it's not really that sophisticated. It's really just a systematic way of trying to look at a problem. So regardless of whether that problem is hepatitis, or whether that problem is cancer, or whether that problem is Ebola, or whether that problem is E. coli, or whether that problem is suicidal behavior, how can we look at this systematically so we can try to develop what we know about the problem, where are the gaps, what don't we know, and how we can target our program to make sure that those things work well. I'm going to get started. I want to show you this kind of down here at the bottom. That's a little disclaimer that CDC, this is a federal agency, right? So we got to kind of work with that. So as a federal agency, they make us put that little disclaimer on there. You don't really have to read it. I'm going to tell you what it says. What that says, those of you who ever watched Mission Impossible, You know, and you know, I know that's the Tom Cruise version, so I go back far enough to see the Mr. Phelps version with the cassette tape. But you know, on the little cassette tape, it says, Mr. Phelps, if any of your crew are caught or killed, the secretary will disavow any knowledge that we even knew who you were, they sent you, and so that's what that thing says. It basically says, CDC has not looked at what I'm gonna talk about, so if I say something, makes the hairs on the back of your neck kind of stand up, and you're like, wait a minute. I will even tell you his name, Dr. Robert Redfield. He is the director of CDC. So if you want to write a letter to him and say, you guys sent Crosby out there, and he started talking all this strange stuff, Dr. Redfield is going to look at your letter, your email, and he'll say, Crosby, I never heard. Who is this guy? So he is going to disavow any knowledge that I was even here. You know, any of that. So I'm just letting you know ahead of time that that's what this situation is. There's my disclosure statement. I know sometimes in hospitals and when we go to medical conventions, we got to say that I'm not endorsing any product, no financial relationships to disclose. And here's some of the objectives for what I'm going to try to cover today. Define injury surveillance. That's just the way we collect information. And surveillance really, in terms of public health, really boils down to kind of three words, and that's information for action. What kind of information do we collect that it can help decision makers? And those can be decision makers at the policy level, at the legislator level. It can be decision makers at a hospital level. It can be decision makers in a community-based organization. It can be decision makers that are working with a nonprofit. How can we get information to them that help them to make the right kind of decisions about what we want to do and how we want to do it and how can we do it better? So that's what it is. And then I want to describe some of the sources of data that can be used for public health surveillance and suicide issues. This is the public health approach, and you can just kind of see it depicted as 4 steps there, 4 stages, and I'd like to depict it as kind of a cycle. Because with almost any human condition, any health condition, we've not eradicated any of them, except for one. There's only one. This is that public health thing. So those of you who are in public health, smallpox, right? That's the only one that we've eradicated. So with everything else, whether that's tuberculosis or whether that's Ebola or Zika or any of those kind of diseases, we're oftentimes doing all 4 of those things at the same time. So we start off with assessing what the problem is. That's the who, what, when, where of any particular problem. What do we know about how it manifests itself? What do we know about the patterns? What do we know about males versus females or young people or teenagers or adolescents? Where is this problem being manifested? What are the trends? Is it going up? Is it going down? What's happening? Geographically, do we know? Is it West Coast, East Coast, rural areas, urban areas? That's part of that assessing the problem. What is that problem? Then we kind of move towards identifying the causes. What do we know about risk and protective factors? That's the why question. If we know that males die of suicide more than females, then we start asking that question, well, why is that? What's going on there that we've got to try to figure out how we can do something about it? Because then that leads us down to the green, developing and evaluating the programs and the policies. Now, if we know some of the why, or we know some of those risk factors, now can we develop that program that addresses the why so that we can try to bring it down? We're trying to figure out what works, what doesn't work, and then move towards that last one, implementation and dissemination, so we can get the word out. Now we got to tell people what we learned in those first 3 boxes. We got to take those programs, especially those ones that work, and now we got to spread them out. We've done a pilot. We've done it in one school. Now we want to spread it to that whole school district. Now we want to take it across the state. Now we want to take it across the country or across the world. So that's the dissemination part. So we're trying to do those 4 things, and then as we look at that problem, it may change a little bit. Or we may have been very effective with addressing suicidal behavior among adolescents. Now we got to come back and we got to look at the middle-aged adults. We got to look at those who are over 65. So now let's develop those programs. Let's understand principles so we can start to do it a little bit better with other groups. All right, so why is surveillance important? Collecting data is just one step. It's just one part of that whole process of what we're trying to do. And the critical goal is to control or prevent diseases or adverse health conditions. That's where the action is, right? So that's where the information for action. So we're collecting that information so now that we can try to do something about it. So it's vital to communicate the results. So while we collect information, I know some of you have been part of organizations where we go through something like a strategic plan. That's sometimes a dirty word at CDC, strategic planning. Oh, and the whole other thing about, reorganization. So as you can imagine, I work for a federal agency, so about every 4 years or sometimes every 8 years, we got to reorganize, right? Because a new administration has come in, you got to reorganize, and everybody starts gritting their teeth like, oh my goodness, what's going on here? So it's vital to communicate what you're doing and what you're talking about. So how did all of that connect? Well, so as what we're understanding about the problem, we've got to make sure that we don't take that organizational assessment, we don't take that strategic planning document, put it in a binder, 3-ring binder, put it up on the shelf, and there it's just going to sit for the next 5 years until we decide we're going to do it all over again, right? We've got to communicate those results to people so that they know, okay, this is what we found, this is what we're going to do with it. So that we make sure that that information gets out, and those people who are being affected or who are implementing that program can take a look at it and say, yeah, that's good, that's where we want to go, or that's not so good, we actually need to move in a different direction. So making sure that that information is communicated to people. So as part of what we're doing with public health, we talk about the assessment. That's how we try to understand what that problem is. That kind of relates back to the surveillance. The policy development, how are we going to take that information and develop a policy, develop a plan for action, and then lastly, assurance. How do we make sure that it's happening? That someone is actually out there doing the work that needs to be done in regards to that program. So as part of that, why do we need these surveillance systems? What's the problem? How big is it? Who is at risk? How do we design research to find out about how to prevent the problem and test it in a community and assess the result of programs? So we do that evaluation, and some of that information is involved in evaluation so that we know what it is that we're doing and whether it's effective or not. Oftentimes we do programs and we sometimes go by, well, the people liked it. Isn't that enough? They came out of there, they did their little evaluation, and they said, yo, I like that presenter, he was great. And did it make any difference? Do we know whether suicide rates actually came down? Do we know whether it made a difference in those populations where we're trying to do something about it? And so we've got to have some of that evaluation component. Those of you who ever have to answer to a supervisor, right, or ever have to answer to a funder that's giving you money, they want to know whether your stuff is working or not, right? They want to make sure that you're able to say that at the end of 6 months or at the end of the year or at the end of 3 or 4 years when we were doing this program, we were able to see a difference. Substance abuse came down or suicidal behavior came down or something else. We made an impact on a particular population. Not that we did it and everybody went home. Kumbaya, that was great. Oh, we loved it. Oh, that was a good hug that you gave me. When we came into this program. No, we want to make sure that this thing is actually working and it's making a difference and somebody is impacted positively by what we did. All right, so why do we do surveillance? Provides data for decision makers, as I just mentioned, helps us to monitor health events. As Mr. Jackson mentioned, and I think I've got a slide coming up later, one of the things that's been going on in the United States, just in case you hadn't heard, because there's so much stuff that's happening in news, stuff that changes every 24 hours, that unfortunately over about the past 10 or 15 years, suicide rates have been going up every year in the United States. Now that's the wrong direction from where I'm sitting, and I imagine from where you're sitting too, that we really want that trend going back in the opposite direction. We want it going down. And so if we don't know what's happening in regards to those trends, then how do we ever make any impact on what's happening? So as we're trying to understand what's going on in regards to suicidal behavior, we can look at what the patterns are that are changing. And I think I had some handouts that there was an article that we just released a few months ago, actually back at the beginning of June, in which we were looking at not only what was happening in regards to the trends in suicide, because we knew nationally they were going up, but what was happening at the state level? Was it doing the same thing in all of the states? Or maybe there were just a few states that were going up and all the rest were staying flat. And one of the things we found out is that when we looked at it, in over half of the states in the United States, suicide rates were going up by over 30%. So it's still not going the right direction. And actually part of what we found out is where it's really going up is especially working-aged adults. those 35 to 64, that's where it was really having the impact, and especially among males. That's where the rates were going up. But if you don't know that, if you don't know which populations are being affected, and you don't know where to target your programs, you don't know where to put your emphasis, you don't know how to try to look at what's happening with the problem. So it's important for us to monitor the events, to set the priorities, assist in the planning, assist in also helping to make, I started laughing because I thought that word rational. I work in federal government. Rational, sometimes we joke with each other, right? We're sitting around the office, we say, that was a rational thought, but that's not the way we're going to end up doing things. But we try to do that as much as possible, make rational decisions about what it is that we're going to do. Sometimes I know you're elected representatives, right? You're elected senators. Sometimes they make decisions that you're like, what? How in the world did they come up with that? Because it doesn't seem like it's rational, but we do try. We try to make rational public health decisions. So here's some of the data that's available. We look at death certificates. Death certificates are wonderful because they are tracked over a number of different years. So for over 80 years in the United States, we've had all of the states report into the death certificate, the vital statistics system. So they're useful in terms of tracking what's going on. But the thing about death certificates is they really have, the way I describe it, is they have name, rank, serial number. That's about all. They don't tell you very much about what might be some of the circumstances or some of the risk factors that may have played a role in that particular person's death. So sometimes when they talk about this person died of a myocardial infarction, they had a heart attack, doesn't say that their cholesterol was 400. Doesn't say anything about they were a cigarette smoker, doesn't say anything about a sedentary lifestyle. So you need some other information in order to try to say, okay, this is the kind of thing, if we're going to take a prevention program and set it in place, we need to know some of these things about risk factors. And that led us to develop, and along with some other partners, to develop that second one on there, which is the National Violent Death Reporting System. And you actually have that here in California. That what that does is it puts together three primary data sources. It puts together those death certificate data, but then it also looks at the medical examiner and coroner information, and then law enforcement information. And part of what it does is it asks some very specific questions about the different forms of violent death that are collected. And on suicide, it has about 20 different questions that it's getting information from that medical examiner coroner, from that law enforcement agency, off of the death certificate, that's asking questions about past medical history, past psychiatric history. Did the person have a job problem? Did they have a financial problem? Did they have some sort of school problem, a legal or criminal issue that was going on, some sort of crisis in the past couple of weeks? Did the person leave a suicide note? So now you've got some more information that you can say, okay, what's going on here that before that person died, these were some of the factors that we can be looking for so that we can hopefully prevent the next suicide. Right now, it's in 40 states, Washington, D.C., and Puerto Rico. We just got money to fund those last 10 states, so we are now in all 50 states with this particular program. So we'll now have that data probably in the next couple of years that will represent all 50 states. This is what suicide looks like. The last data that we got for the full United States shows that there were about 45,000 suicides in the United States. That's a suicide about every 12 minutes. So that's pretty serious in terms of what's happening with suicides across the country. This is what the suicide rates look like over about the past 80 years. And this is based just on death certificate data. So let me point out a couple of things with this, and then let me make sure that I move on, because I know I don't have all morning here. I have to apologize, right? I should point over here, because I keep pointing over here. So all of you people are seeing everything, and the folks over here are they're getting mad at me, because I'm not pointing to anything over here on this side. All right, so one of the things to look at here is when you look at suicide rates, especially since about 2000, 2005, that they are going up among males, that's the total, going up among females. One of the things to note here is the highest suicide rates that we ever had in the United States were during the early 1930s, late 1920s. Now, some of you that studied history, I'm not sure if anybody's been around quite that long, but some of you that studied history know that what was going on in the United States during that time, right? Great Depression. So while we understand that mental illness is one of the biggest risk factors for suicidal behavior, we can't forget that an economic phenomenon can also be a precipitating event for suicidal behavior. We actually did a study from several of us in suicide that work there at the Division of Violence Prevention on two different aspects of this. So one was we looked at all of the business cycles, and that's the way our health economists, that were working on this study, kind of describe what's going on. So there's been business cycles in which the economy has gotten better, economy has gotten worse. Not just the Great Depression, but there's about 12 different business cycles between the 1920s up to about the mid-2000s, about 2005, 2006. And so part of what we wanted to do is, many people have studied the Great Depression. Definitely. Unemployment, those things were associated with suicide. Not a cause, but associated with suicide. But what about those other 12 business cycles in which the economy went up or got worse? And what we found, it was consistent. Over those 12 different business cycles, that when the economy got bad, suicides went up. When the economy got good, suicides dropped down. And especially when you were talking about those between 25 and 64. Working age populations, right? That's what was happening in regards to suicide, that it was fairly consistent across that whole time period. So it's not just the big phenomena, and we could talk about the Great Recession right here, right? 2008, 2009, that can be a contributor. Suicide rates are still going up, so that's not the only thing, but that definitely contributed to what was going on in regards to suicidal behavior in the United States. So it's something that we got to pay attention to. I mentioned there were two studies. There was another one we did using that National Violent Death Reporting System, in which we looked at evictions and foreclosures as a reported condition in regards to people that die as a result of suicide. And that's not going to be a surprise to you, right? That what we saw during that 2007, 2008, 2009 time period, evictions or foreclosures as one of the precipitating events in regards to suicides were increasing. Just as suicides were increasing, that was a precipitating event in regards to suicides. All right, move on. These are some of the variables in that National Violent Death Reporting System specifically on suicide. So, ever treated for a mental illness, other mental health diagnosis. You guys want to guess? Which is one of the leading things that we find when we look at what are some of the circumstances associated with suicide? Relationship problems. Over 40% of the people that we have as suicide decedents in the National Violent Death Reporting System, over 40% are reporting a relationship problem as being a contributor to. When we ask their proxy, we ask that next of kin, we ask a friend or a family member, what was one of the contributing factors to the suicide? A relationship problem. So now we've got to think about, when we're developing prevention activities, we work with this in regards to the military, in regards to the VA. Okay, how do we develop helping resources for people that are having relationship problems? Maybe they're going through a divorce, maybe a separation, maybe some other things that are happening, because that might be the thing that is the trigger. Again, it's not the cause, but it may be one of the contributing factors that puts somebody at risk for thinking about suicide, is that relationship issue. There are other ones in there too, and if we have time, we'll talk a little bit about those. This is a study that we did with that violent death reporting system, looking at, we work with the Department of Defense and we work with the Department of the VA to try to take a look at it. And so here, one of the things up here, intimate partner problems. Over half of those that died as a result of suicide, that was the thing that was reported as a precipitating circumstance of their suicide. And then also mental health problems, over half, and then with both. And that's one of the things. When we talk about suicidal behavior, it's not going to be a surprise to you that people rarely, if ever, engage in suicidal behavior just because of one thing. It's not just a single thing that puts somebody at risk for suicide, but oftentimes it's an interaction of multiple things. So it may be the job problem and the relationship problem and the mental illness that puts somebody at risk for suicide. So how can we intervene with one of those things? We may not have to intervene for all of them, but can we intervene with one of them that puts somebody, that we can help protect somebody? This is some of the data from several years ago, just in regards to looking at that violent death reporting system, one in which we also did some look at American Indian and Alaska Native populations, but it allows us to kind of look across some different populations, whether that's by age group, whether that's by race, whether that's by ethnicity, whether that's by region of the country or state. And we just wanted to show here that, again, you can see those with a current mental health problem, what percentage are reporting that, also intimate partner problems. This is when we look at blood alcohol concentration. So when we use that National Violent Death Reporting System and we use some of that medical examiner and coroner data, that oftentimes they will do a toxicology analysis on the suicide decedents. And here you can see that one of the things that we kind of remarked on when we looked at that is that when you talk about measuring alcohol in decedents, that from 10-year-olds all the way to 60-year-olds, there was alcohol present in every age group. It didn't make a difference what you were talking about. 10-year-olds, right? That's elementary school age, not the majority, but still, you're seeing alcohol present as a contributor, maybe, to suicide in 10-year-olds, 20-year-olds, 30-year-olds, 40-year-olds, 50-year-olds. And then we did some other measures in which we're talking about greater than 0.8. That's the legal level of intoxication. So even here, you're seeing 10-year-olds in which some of them are measuring over the legal limit of intoxication in terms of alcohol, these that are dying as a result of suicide. So important for us to take a look and understand what are some of the other contributing factors. Here's some of the problem description. We're also talking about some of the non-fatal information. So we have some systems that also look at emergency department data. Sometimes looking at your state hospital association, local hospital trauma center. There's another system that we have in which we work with the Consumer Product Safety Commission to utilize their sentinel hospitals across the country to collect information about how many people are coming to emergency departments for visits related to self-harm, in which we expand the definition a little bit. So not specifically suicide attempts, but also some of the self-harm, some of the self-mutilation, some of the cutting that some people engage in. So it's looking at all of those behaviors, purposeful behaviors in which someone is hurting themselves. This is a description of that system, National Electronic Injury Surveillance System, operated by the Consumer Product Safety Commission, in which we're looking at all of the different cases that occur over the whole United States. These are some of the variables that are collected there. What was the intent of the injury? Some of the major mechanisms. We're looking at age, race, sex, and some of the other things that are there. This is some of the information in regards to looking at that self-inflicted injury. Oops, wait a minute, let me back up. Just to point out, okay, I'm gonna stop hitting the wrong button in just a minute. That's the one I want to talk about. Stop, don't move. Okay, here we go. One of the things I just want to point out here is when I showed that slide about what was happening in regards to suicide rates around the country. One of the things that you might have noted there is that males die of suicide about 4 times higher than females. Male rates are about 4 times higher. But when you look at non-fatal, this is emergency department visits, you can see in almost every age group, females in the orange, higher than males. Especially when you're talking about adolescents and young adults. That's where you see the highest non-fatal is among females and among younger age groups, as opposed to when you look at deaths due to suicide, as I mentioned, where it has been going up is among middle-aged males. Very different when you talk about non-fatal. So again, how does this information inform the programs? Well, if I've got a program where I'm trying to target prevention of death due to suicide, I might target my program at males, because they might be the population at greatest risk of dying as a result of suicide. But if I'm trying to target non-fatal suicidal behavior, suicide attempts, I might target my program at females, and maybe especially adolescent and young adult females. So again, how does that information help you in terms of thinking about the program? Doesn't mean that you might not do a program for everybody, right? There's maybe a risk across the whole population, but if I have strategic information about what I want to do, and I have unlimited money, right? I know all of you have unlimited resources for doing your program. Well, then you can do it across everybody. But if you have limits on your resources, then you may have to target that population you think is the highest risk. Let's start there, and then let's spread it on out and do some more with some of the other groups. This is another system that we're looking at, the National Syndromic Surveillance System. Maybe I kind of show this one to you as one of the ways that we have to be creative with federal government. This system was developed right after 9/11, in which we were concerned in the country about bioterrorism attacks. And some of you remember there was an anthrax attack that came right after that, in which somebody was putting anthrax, powdered anthrax, in the mail and sending it out to various news media outlets. I think they also sent some to some of the senators. So they developed this system initially to look at syndromic surveillance. We've adapted it to look at things like influenza-like illness so we can track it. This is one of these things that we call real-time surveillance, in which we're getting reports on this system within 24 to 48 hours of people that are coming into emergency department visits. So what we're doing now is we're adapting this system to look at people that are coming to the emergency departments for suicidal thoughts and suicidal behavior. So we can kind of track what's going on and be able to, talk to, whether it's the local health department, whether it's local hospitals, to say, okay, this is the resources. You're seeing an increase in the number of people that are coming into your emergency department for suicide attempts or suicidal ideation. What's going on here? Folks in New York City, and I'll show you something else here, right after the Kate Spade and Anthony Bourdain suicides back in early June, they started seeing an increase of folks coming into emergency departments. As you remember, Kate Spade was in Manhattan when she died as a result of suicide. So here's the influence on those kind of things that may happen so that you can kind of track it. This is when we started to look at some of the different codes. So you have to develop codes for it. I just want to show you one other thing. Suicide attempts among 10 to 19-year-olds treated in U.S. emergency departments January 7th through September 1. All right, so I'm going to ask you another question. I remember I asked the last question and I answered it, didn't I? I did. All right, so does anybody know during this particular time period what was going on in the U.S. that we started seeing this increase of suicide attempts in emergency departments? Anybody know what was going on? High school, unfortunately, they've been going on quite a while. So it wasn't just one high school student at that particular time. Okay, so can I give you a clue? What? Not the Pokemon thing. It did have something to do with media. Not so much social media, but something that was coming on television. 13 Reasons Why. That's when 13 Reasons Why was first started airing. So while we can't say, based on this emergency department system, that was the particular reason, it sure does have a correlation. That's part of what we do as epidemiologists. Okay, is there an association between this phenomenon that we're looking at and something else that's going on? So we're doing a study right now so we can do a little bit more definitive analysis of what was going on. But that's when 13 Reasons Why was coming on television, right during that period of time. Right? All right, wait a minute. I'm reaching in my pocket because I'm looking at what time is it. All right, yes. All right. Mr. Jackson says I have all I need, but I know we've got some other presenters here. All right. Anyway, so there's the little arrow, right? That's, because we as epidemiologists, we might forget what we're talking about. So we put a little arrow in there so we know, okay, that's when the thing happened. 13 Reasons Why, right there, April 9th through 15th. That's when it first came on. All right, so some of the other data that we also take a look at, we also look at surveys. So we look at things that are like more official medical records. So whether that's death certificate information, emergency department visits, hospitalizations, we've got some records that we try to take a look at there. But you guys know, just like I know, that there are a number of people that think about suicide, that seriously consider suicide, that make suicide attempts, that never go see a healthcare provider. right? They make a suicidal behavior, they engage in suicidal behavior, they wake up the next morning, they never tell anybody about it. And so part of what we do is we try to develop surveys that are anonymous, confidential surveys in which we ask people, and we ask high school students, and we actually have some that ask adults, in the past 12 months, have you thought about suicide? Have you made a plan? Did you make a suicide attempt? Did you make an attempt that required medical attention? So we've got some information about that too, that again helps us look at what are the patterns in regards to suicidal behavior. This is the Youth Risk Behavior Survey done every other year on the odd years. Some states have a different name to it, so I'm sure California probably does it. I just don't know exactly whether it's called California YRBS or they may have a different title to it. Administered in school, computer assisted, has information at the national, state, and sub-state level. These are the 4 questions looking at the national information. Again, kind of taking, see. It's tricky, right? All right, here we go. So the other thing to point out here, did you seriously consider suicide in the past 12 months? Did you make a plan? Did you attempt suicide? And did you make a suicide attempt that required medical attention? One of the other things to note here, females higher than males in every one of those categories. This is one of those things, so I'm going to give you the epidemiologist terminology, statistically significant. That means when you measure this across a confidence interval, that the difference between males and females is a real difference. That's all. It's statistically real. Is it a real difference, or is it just, within a margin of error? No, it's a real difference. Females report more than males across all of those different categories. One of the things that we've been able to do with some input from external partners is we have made sexual orientation and sexual identity a core part of that youth risk behavior survey. For a long time, when they started it back in the 90s, there were only certain states that wanted to put those questions in there. There's some states, I guess I can say it this way, there's some states that think if you ask somebody a question, if you ask teenagers, because this is the youth, ask teenagers a question, they'll start doing it. Right? So they don't ask, some states didn't ask the sexual behavior question. If you ask them about sex, they'll go out and do it. No, that's not really true. And some that didn't ask the suicide questions either. We asked teenagers about suicide, they'll go out and engage in suicide. No, you don't introduce the idea of these things when you ask about some of these behaviors, some of these health behaviors. And so there were some states that didn't want to ask about the sexual identity question, so we had to come back and put it into the core now. So now it's in the core that every state now will be asking these kind of questions. Part of the reason I show you this is when you look at those that identify as lesbian, gay, bisexual, they report more in regards to suicidal behavior, making a suicide attempt, and those who are unsure than heterosexual. So again, how do you target those populations that might be at greatest risk? You've got to have that kind of information that you can say, this population is at risk. We need to put some resources into trying to address what's going on with that particular population. This is just to give you an example of the pyramid and why we try to collect data at various levels. So from the deaths are really just the tip of the pyramid. There's something that's important, and we want to try to prevent deaths due to suicide, but we also want to try to prevent the hospitalizations, the emergency department visits, the suicide attempts, and those that seriously consider suicide. This is looking at those over 18, so looking at several different sources of information for adults. So here, about 40,000 deaths, and this is going back to 2014. In the parentheses are just kind of looking at the ratio. So for every 1 death of an adult in 2014, there were 27 adults that say that they had made a suicide attempt in the past 12 months, and over 200 adults that say that they had seriously considered suicide. One of the things that, again, research has shown us is that the group that's at greatest risk of dying as a result of suicide are people who've made attempts before. So it's important for us to know this information too, because we've got to try to reach those folks, to try to make sure that they don't move up here. All right, so a lot of the information that I just talked about is available on CDC's website. There's ways that you can go on that website. You can look at it nationally. You can customize kind of what you want to look at, whether you want to look at it by males versus females, whether you want to look at it by age group, whether you want to look at it by race and ethnicity, whether you want to look at it by a particular state. So you can take a look at all of that kind of information, and then some of that information about emergency departments is also on there. And those are some of the features of that system that you can take a look at. There's different ways to try to analyze the data. I'm going to go for about 2 more minutes, and then I'm going to stop. So you can look at time, place, and person. Those are kind of the typical characteristics of what we look at. What's happening over time? How are things changing as you look across years, or even if you look within seasonality? You know, one of the things that we've looked at is when you look at deaths due to suicide, they're not even across the whole year. And while you oftentimes hear in the news media that they think suicides go up during the holidays, especially Thanksgiving and Christmas, I'm about to give you permission. Even though I know some of you have those giant flat screen TVs that cost, you know, a couple of $1,000s, so I don't want you to do this, but I'm going to give the others of you that have cheap TVs, I'm going to give you permission to do this right now. Is you can take off a shoe and you can throw it at the television. Because what we found when we looked at the data is actually deaths due to suicide go down during November and December. They actually are higher in the spring. And there's actually a different pattern if you look at school-age children. School-age children, it actually goes up in the spring and in the fall, right when school starts. So it's not during the winter, it's actually in different times of the year. But again, you know, news media go off of stuff, I don't know where they hear it from, but they didn't hear it from me. So I'm gonna give you permission, right? Take off that shoe. Like, no, you're not telling the truth. That's not right. Yeah, so you can do that. You can do that if you want to. All right, so you have a change. What's going on? How do you interpret what's happening in regards to the data? You've got a count, you've got a ratio. There are ways to try to take it and do the analysis so that you understand, what does this really mean? I've got some numbers here. What is it telling me about which populations are at risk? Where's the greatest number? Where is this happening? And maybe even geographic location. Are they happening in the home? Are they happening in the school? Are they happening in the hospital? Where are these events happening that I can, again, try to target a specific intervention? All right, consider the factors which may have contributed to what's going on. Sometimes there's a change in coding. One of the things that we also have to look at is there's this thing called the International Classification of Disease Codes, in which about every few years, it's generally every 5 to 10 years, they change the codes. And there's actually been a change in the codes, what they call clinical modification codes, ICD-10-CM, that really influence what you code and how you code things that come into emergency department, non-fatal information. And the change of the codes from 9 to 10, so this is information, some of you are like, okay, like, would you move on? Because this is like really boring. That there was a change in the codes, that now we're seeing a change in the counts for non-fatal suicidal behavior. But it just had to do with the way the codes changed. Not because the behavior had changed or because the number of people had changed, it was because the codes changed. And one of the big things about this change from 9 to 10 was that it wasn't a seamless code. That when you looked at the change from 8 to 9, you could pretty much track, okay, this changed, that code changed, it basically means the same thing, a little bit of wording. From 9 to 10, they changed a whole lot of definitions. So it made a big difference. So we're working with some of the folks that do coding. There's a National Center for Health Statistics to try to make sure that here's the translation, right? You got to translate things from one thing to the other. We're doing a translation of that to make sure folks are doing that right. All right, look at other systems, try to see what's happening there. So you could look at fatalities, you could look at non-fatal to try to make some correlation between what's happening with deaths and what's happening with non-fatal so that you can kind of collaborate it. Don't be color biased. That's oftentimes because the way we depict stuff in epidemiology, we usually do the dark colors to be the bad stuff. So you got to be a little bit careful that you don't look at a map of something and because some colors are dark, oh, the bad stuff is happening over there in Colorado. This may be, you know, that day I decided I liked purple and I just put purple in, you know, so just be careful about doing that when you're interpreting some of the stuff that we do. That's CDC, we do that too. So not all apparent increases in disease occurrence represent true increases. So sometimes there's been changes in population. So what is the denominator? What do we know about what's happening with census information, improved diagnostic procedures, enhanced reporting, and duplicate reporting? All right, so I'm going to conclude, right? Assessment is a foundation for public health action, so we need to know the numbers. In order to try to make decisions, informed decisions about what we're going to do, we've got to have some data. We oftentimes talk about, across CDC, we want to be data-driven but community-sensitive. We want to have the information that tells us, okay, this is what it looks like we want to target, or this is where we want to make that focus, but we need to hear from the community. We need to hear from those that are being impacted about whether that makes sense or not. Should we be doing this here in this population? Should we be doing this at this particular time period? Should we be doing this in the schools? Should we be making this collaboration between the schools and the parents and those in the community? How do we understand that these things got to make sense in regards to not just the numbers, but there's other information? Existing systems for assessing injury are useful, but have their own limitations. We do like to talk about at CDC that we have the data and we're so smart and we know everything, but they have their limitations. You got to understand that data doesn't tell you the whole story. It can tell you some of what you need to know, but there's other information you got to add into that. And the need exists for improved and expanded surveillance systems regarding injury. We're still trying to improve on what we do, trying to make it a little bit better, and try to understand all of the different nuances, all of the subtleties, all of the other things that you don't get unless you're talking with people about what makes sense. So you can't get it all from records. You got to talk to people and understand what's going on. So we're still trying to improve and try to make things a little bit better. I'm going to stop right there. Thank you for your attention. I think we've got a couple of minutes. Maybe that's why I talk for so long, so you can't ask me too many questions. We got a couple of minutes for questions, and then we'll move on to the next thing. So, any questions? Yes?
We'll have somebody come with the microphone. Here you go.
Thank you for that. It was very informative. I have a question. You commented on the coding change and how that is hopefully refining for non-fatal attempts. Given the CDC's data on opioid-related deaths, for example, and all drug-related deaths, and that those may be underestimated, I'm just wondering what your thoughts are in terms of how well refined they are, given the increased risk of suicide with substance use, and what are your thoughts about opioid-related deaths with how these are being reported?
Well, that's a good question. So there was at least one person that was paying attention to that coding stuff that I was talking about for a minute. That's an important issue, and there are several researchers around the country that are looking at some of the issues about self-harm in a broader context, in which they include things like substance abuse as a self-harm kind of condition. And so in saying that, we've got this thing where, oftentimes in terms of how we get funded, things are very categorical. You're going to get money to do opioid prevention. You're going to get money to do suicide prevention, and never the twain shall meet, right? But we understand, as you mentioned, that suicidal behavior, substance abuse is one of the biggest risk factors for suicidal behavior. And so now part of what we're doing at CDC, because there's been a big influx of money to look at opioids and look at overdose poisonings, is we're now talking about this overlap between the two and trying to merge some of our data sets to try to take a look at that, not only merge the data sets, but merge the prevention programs to try to take a look at this issue. One of the things that we've also noted is that at the same time that suicides have been going up, opioid deaths have been going up. And when you start looking at the patterns look very, very similar. When you look at some of the demographics of who's dying as a result of opioid overdose, who's dying as a result of suicide overdose, especially males, especially middle-aged populations, started in rural areas, started moving now into the cities. Suicides, males, rural areas, middle-aged populations. You start looking at some of the risk factors, there's a lot of overlap there. So we believe that the phenomenon are not separate out here. Those phenomenon are probably, the kind of Venn diagram with some of the overlap there. That's probably what's going on. So we've got to think about programs that probably have an impact on both of those two. Oh, the other thing too, in terms of the patterns, have to do with what's happening in terms of job layoffs and the economy. that also contributed to both opioid deaths as well as suicide deaths. So we're now trying to look at how we relate to those two kind of things. One of the other things that we're also doing is, some of you may be familiar with what's called the adverse childhood experiences information. That too, risk factor, when you ask people about what were their experiences as children, whether it's victim of child abuse and neglect, exposure to violence. So not just were you a victim, but were you exposed to violence? Did you have a parent or a guardian that had a mental illness problem, a substance abuse problem, or was incarcerated? Risk factor for substance abuse, risk factor for suicidal behavior. So now how can we try to prevent those adverse childhood experiences from happening, or intervene in those that have been exposed to that, so that we could try to prevent some of those adverse outcomes? So that's what we're trying to do now, is try to integrate some of those different activities so that we can target those populations, because there's a lot of similarity between those two. All right, yes.
Thank you for a really wonderful an informative presentation. My question concerns if there has been any evaluation of the length of inpatient stay after suicide attempts having an effect on repeat attempts.
You know, I don't know about the length of stay, but I know that we have been working with several other federal agencies, including SAMHSA, Substance Abuse and Mental Health Services Administration, with this program called Zero Suicide. And what that program has done, they started this off with the Henry Ford healthcare system in Detroit, and then I think there were some folks with Magellan in Arizona that did this, is trying to look at this issue of continuity of care and trying to make sure that anyone in their healthcare system, if they had been identified as any kind of risk for suicidal behavior, that you're trying to make sure that clinicians across their whole healthcare system knew about this particular individual, to make sure that they had, you know, what oftentimes they used to talk about in social services as wraparound. We're going to make sure that that person is connected wherever they need to go to make sure they're getting the services they need. So I'm not particularly familiar with the length of hospitalization for those that might be at risk, but definitely the issue of, once those folks are discharged, to make sure that they're getting that next appointment, that someone's following up on them, and that you're making sure that they're getting all the services they need and they don't fall through the cracks, right? That you're making sure that all of those kind of things are set in place, that you don't have to worry about that person's got to make a call. We're going to call for you. We're going to make sure that someone is contacting you to make sure that the next thing that you got to do, whether that's your primary care provision or whether that's the behavioral health, that all of that is being set up. So that we know, the Henry Ford system was able to, once they integrated that care, that's why it's called Zero Suicide. They were able to drop their number of deaths due to suicide down to zero. It's bounced back up a little bit, but not back to where it was because of the integration. Yes?
What about services for teenagers who want to change their sexual identity now?
No, that is beyond what I can tell you specifically about, other than knowing that people that are going through that transition, you know, that are going through this period of time in which there's vulnerability and there's stressors, those kind of things we know can contribute to suicidal ideation and suicidal behavior. So it would make sense, although I can't say that I know specifically about that kind of situation, but people who are going through that stressors, you know, whether it's the, you know, transition from elementary school to middle school, or transition from middle school to high school, or transition out of high school into, you know, whatever is the next step. You know, all of those kind of things can be periods of time in which someone is experiencing a lot of stressors, and so what are we doing to make sure they're connected to the right kind of supportive services or supportive people in their community or in their environment that keep them protected. I know we have some questions over here and some back over here, and I know it's almost for kind of the next person.
Thanks, Alex.
So let's go here and then we'll come over.
Sean?
Sorry, yes.
Alex, I'm a little confused because we cite the Centers for Disease Control when we do some of our research. And some of the numbers that you've given seem to conflict with some of the numbers that I see on the CDC. But also there's things like precipitating events. Mental health seems to be isolated or segregated from some of the other problems. But they all seem to be related to depression. And I know from the CDC, I believe that one of the statistics are about 90% of suicides in this country are related to depression.
When they do psychological autopsies, and it's not studies that CDC has done, but that other researchers have done, what they'll find is in 90% of those people that die as a result of suicide, there were symptoms that were consistent with mental illness and especially with clinical depression. That includes substance abuse in that 90%. Now, when we ask those kind of questions in the violent death reporting system, we separate out some of those things. So it won't, you could add it back up to 90%, but it won't be 90% in any of the individual categories. One of the other things about that, when they're doing psychological autopsies, is they're going back and they're asking friends and family about symptomatology of the person that died as a result of suicide. One of the things we found is that for many of those folks, doesn't take away that 90%, but for many of those folks, they hadn't been seen by somebody or had never been diagnosed. And so part of what we try to emphasize is that 90% is still correct. It's just that you can't wait. I'll put it this way, you can't wait for those folks to come into clinical care. You're going to try to identify what might be an event that might be putting that person at risk, because what we found is that for about 54% of the folks in the violent death reporting system that had died as a result of suicide, they'd never been diagnosed.
Yes, CDC was also part of a white paper that came out showing that isolation is the leading predictor of suicidal behavior. Do you agree with that?
Social isolation, yeah. People who don't have that network of friends and family are generally at higher risk for suicidal behavior. And the opposite, though, is also true. People that do have that social support, it's a protective factor against suicidal behavior. So part of what we're trying to do, again, working with other organizations, is promote things like connectedness. So how can we make sure that people are connected to, it's family members, connected to others within their community, connected to organizations, whether it may be faith-based organizations, maybe at the gym, it may be at work, it may be at other places. How do we make sure that people are connected so that when they do run into difficulties, relationship problems, that they got somebody they can talk to about it?
My last question, and I'll make it really quick. Some of the statistics that we're given here also, as far as providing resources, we know that on college campuses, suicide is probably the leading cause of death. Or suicide is probably the leading cause of death. Between 14 to 24, it's the second leading cause of death. What resources are going to primary and secondary schools? Because they seem to be much higher, even from the slides, than the people 65 and older. Thank
Part
you.
of what we're doing is we just released something I just didn't have time to talk about. I was focusing on data, is a technical package. And what that is, we put together this technical package across several areas in violence prevention. It's really talking about what are the evidence-based programs that are available. And so we go through and we talk about them. We have 7 different categories of, I'm trying to think if I got a slide on here. You always deal with, that's actually the cover of the document. Let me see if I've got, that's the major categories in that technical package. So part of what we've done is we said, we've gone through and looked at the evaluation research to be able to say these things really have evidence that they work. These are successful. And so we're now putting out that document, and we're developing next is an implementation guide. So here are the kind of programs that work. Now, how do you do them? So we're working with schools to try to do that. One of the challenges you have with schools is, of course, they got to teach reading, writing, and arithmetic, right? So putting in health programs, we've got to try to work with those that are administrators, superintendents in the schools to understand how can we integrate that into some of the curriculum in the schools. And so that's a difficult thing. You got to make sure that you're doing that correctly. I know we are almost out of time. Okay, last one.
Last question.
Hold it.
Okay. Has there been a study on geriatric population, 65 and over? I have been to several of the suicide seminars, and there seems to be no study for them. Is there a reason why?
There are some studies that look at that population. You probably are aware that for some populations, there's not as much research that's going on in those particular groups. But there is some among those over 65. As I mentioned that suicides among males about 4 times higher than females, that kind of translates into there's much less research on suicide among females, right? Because the 80%, folks do the research on that 80% and not on the 20%. But the same kind of thing, when they look at suicides among older adults, I didn't show this slide, but I do have a slide that talks about, when you look at males versus females and by age group, especially males over 65, suicide rates just start to skyrocket. So there has been some work. One of the leading researchers, or two of the leading researchers in this area, Yates Conwell at University of Rochester in New York, and John McIntosh, who's at Indiana University, have done some work looking at suicidal behavior among older adults. And what are some of the specific kind of interventions? What do we know about the patterns? And then what are the specific kind of interventions? So there is some, but not a whole lot. I would probably say when we looked at all of these different kinds of programs, there was probably only about one or two that were specific for older adults, but there were a couple. So there were at least a few, but not as much. So again, here's an area in which the research and the data is limited. There is some, but more needs to be done.
Thank you.
You're welcome.
Well, I'm going to jump in here and say that was amazing. Please give a big round of applause, Dr. Alex Crosby.
Welcome.